So if we look at the chest wall, the skin is damaged. The pectoralis, underneath the skin, we have the fat damage. Underneath the skin and fat, we have the pectoralis major muscle damaged. Pectoralis minor muscle might have been damaged as well. And on top of that, I'm not sure this wound is deep and going into the thoracic cavity, which means like external intercostal muscle, internal intercostal muscle, and innermost intercostal muscles. They might have been damaged. Then if they are damaged, pleura is at risk, and this patient can easily have the pneumothorax. Yeah, pneumothorax means the air in the pleural space. If it is too big, then that will impede the lungs, and this lung is going to get collapsed. Okay, and anything else here, we have the heart on the left anterior chest wall. Is very closely related to the heart. Look at that, this patient even vivid. I mean, everything rip off, like, I mean, everything damaged. So yes, if you see this sort of patient, just relax, pull yourself together, and don't forget the airway, breathing, the circulation. Of course, in this patient, you know, it is the wound, big deep wound. Look at the finger going into the wound. Might be a thoracic cavity, or might be an abdominal cavity, or might be both. And you know, just don't worry about that. Just cover it up, close it, make sure the airway is patent, make sure the breathing is in, make sure if there is any major bleeding, you control it and get help. You won't be alone in this scenario. But let's look at this simple term. Like, you know, we saw the injury on this area. That means the ribs might have been fractured, intercostal muscle might have been damaged, intercostal neurovascular bundles, as you remember, like VAN from top to bottom, vein, artery, and nerve, intercostal neurovascular bundles must have been damaged. And of course, it will damage the pleura as well as the pericardium. So yes, that injury we saw was very close to our heart. So where is our heart? Our surface anatomy. So our surface anatomy, hey, look at that. This is the third costal cartilage. Yeah, this is number 3 rib. We have 12 ribs on the right side, and we have 12 ribs on the left side. On the right, the ribs come out from the spine, and then gradually come here. The bone doesn't get to the sternum; it has to connect with the cartilage. Yeah, so intercostal cartilage. So the number 3 intercostal cartilage just on the right side of the sternum. Number 6 intercostal cartilage just on the right side of the sternum, and number 2 intercostal space. Intercostal space means in between 2 ribs, and that is another point. And this is the 5th intercostal space in the mid-clavicular line, a line which is directly drawn from the midpoint of the clavicle. So mid-clavicular line. This is the surface anatomy of the heart. This is where we expect our heart is situated. So the wound we saw on our previous damage might have damaged the heart as well. So if we really explore the thoracic cavity, this is our anatomy. Yeah, so you can see the right lungs and left lungs, and in between right lungs and left lung, and anteriorly, look at that, anteriorly, we have the sternum. Look at the anteriorly, we have sternum, and posteriorly, we have the spine and the vertebral bodies. Right lungs, left lungs, and this is this area what we call mediastinum. So don't forget the term mediastinum. Mediastinum. So if someone asks, hey, what is mediastinum? Mediastinum is a is a space in between two lungs, and anteriorly it is bounded by the sternum, and posteriorly it is bounded by the thoracic vertebrae. It contains our heart and the great vessels leaving the heart. So that is what we call mediastinum. Yes, inferiorly it is covered by the diaphragm. So that is mediastinum. So I believe you all know that what a mediastinum is and the contents of the mediastinum. So the contents of the mediastinum is our heart and the great vessels. That is the contents of the mediastinum. Of course, if you are doing the cadaveric dissection, this is what you are going to see. This is the right lung, this is the left lung, and this is the our heart. This heart is usually in a boot shape, and all the major vessels coming in and out of the blood vessel, and that area is called the mediastinum. Right, now you are looking at a chest x-ray and x-ray of the chest. So this is the right border of the heart. This is the inferior border of the heart, and this is the apex of the heart. So I hope you remember that homework. You know, one of the homeworks we have is what is this made of? What is this made of? And what is this made of? So if we go back to the previous structure, and this right border of the heart is made by the right atrium. Inferior border of the heart is made by the right ventricle. This is the right ventricle. Look at the mainly. And of course, apex of the heart is made of the apex of the heart is made of the left ventricle. So that's what I want you to relate this previous drawing to your clinical practice, which is the right side of the heart, right border of the heart is made of right atrium. Inferior border of the heart is made of the mainly right ventricle, and apex of the heart made of the left ventricle. And of course, left ventricle might contribute to the small portion of the inferior border of the heart. And if you keep looking at this diagram, if you keep looking at this X-ray, and the heart is sitting on the diaphragm. Yeah, the heart is sitting on the diaphragm, and you all know that right diaphragm is higher than the left diaphragm, because on the right side, in the abdomen, we have the liver, so that we push the lungs a little bit more upwards. And therefore, the right diaphragm is higher than the left diaphragm. And you have seen the X-rays already. If the diaphragm is damaged, it will go even higher up. When there is a phrenic nerve injury, then we have the diaphragm paralysis, diaphragm no longer working, and the diaphragm will go higher. Okay, on top of that, inferior border of the heart, if you look at that, inferior border of the heart is sitting on the diaphragm. Look at that. So that means if something goes wrong in the heart, for example, myocardial infarction for the right ventricle. So this is mainly made of the right ventricle. So right ventricle, myocardial infarction involving the right ventricle will present or might present as like a epigastric pain in the epigastrium, because they are very close. And at the same time, the epigastric pain, like your gastric reflex might give you like a burning chest pain. So just a bit careful and make sure that we are thinking the right thing. So now I said myocardial infarction involving the right ventricle can present with the epigastric abdominal pain, and epigastric abdominal pain because of the acid reflux might give us a heart burning sensation, and you might be worried about. So if you are in that scenario, what do you need to do? You need to think, hey, what are the risk factors? Of course, most of the epigastric pain, burning pain is gastric reflex, isn't it? So, but on the other hand, like depending on the age of the patient, other related medical issue, like do they have ischemic heart disease or any atherosclerosis or high lipid, depending on that, you can make a judgment. And this is the apex of the heart, which is within the mid-clavicular line in the fifth intercostal space. Now, from here, just a little bit, one more step. If you look at this area, you can see the shadow here coming around. You can see another shadow here coming down. And in between these two shadows, you can see the black area. Of course, these are the tips of the spinous processes. So what is this? This is the trachea. Hey, look at that. You can see the trachea, which is in the midline on this X-ray, and trachea is now dividing into right main bronchus, and now here dividing into left main bronchus. So now you are looking at the chest X-ray and you are applying your anatomy knowledge. Yeah. So right border of the heart, right atrium, inferior border of the heart, mainly right ventricle, might be a little bit of left ventricle, and the apex of the heart is the left ventricle. So this is our knowledge, and we are applying this knowledge to a chest X-ray. Right. So chamber of the heart and their surface representation, right atrium, right border of the heart, right ventricle, most of the anterior surface and inferior, left atrium, most of the posterior surface of the heart, and left ventricle, apex of the heart, and most left inferior. Oh, okay. Right. So if you look at that, the heart is here, and now you are thinking about the valves inside the heart. Valves inside the heart, they are pulmonary valve is the highest. Tricuspid valve is between the atrium and ventricle, so it is on the right. Mitral valve is between the atrium and the ventricle, so it is on the left. And aortic valve is lower than the pulmonary valve. What is the importance of this? Of course, when you have a stethoscope, and this is where you listen the heart sound. So what I want you to do is allow your neck just in the middle of the neck, and if you track down with your index finger, and you will get to the Xiphi-Stannard notch. Hey, look at that Xiphi-Stannard notch. From notch, if you go down like about 1 or 2 inches, you will get to the angle. This is the junction of the manubrium sternum and the body of the sternum. And sternum has another portion, which is what we call Xiphi-Sternum or xiphoid process. Xiphoid process, Xiphi-Sternum, manubrium, and body of the sternum and manubrium sternum. And this sterno-manubrial junction, sterno and manubrial junction, this is where the second rib, number 2 rib, come and join the sternum. Look at that, yeah? So just below the, in between the second and third rib, which is called the second intercostal space. Look at the second intercostal space. This is where you listen the heart sound, which is for the aortic valve. And so on and on and on. Tricuspid valve, although we saw that it is on the right, it is more on here when you listen. And mitral valve, which which is between the left atrium and left ventricle. But when you listen, you have to listen slightly more outside, away from the apex of the heart. This is the mitral area, and pulmonary is opposite to the aortic. Yes, once you have your stethoscope in your hand, you can listen this area: aortic, pulmonary, tricuspid, and mitral. Now let's look at the heart. We have the right atrium and right ventricle. As we saw, it will contribute to the inferior border of the heart, and it is the anterior surface of the heart. Left ventricle contributes to the apex of the heart, and of course that will contribute to the inferior surface of the heart as well. And left atrium here, which contributes the most of the posterior surface of the heart. So let's look at the coronary arteries. Of course, coronary arteries, these are going in between the groove of in between the ventricles. So if we look at that, between the right atrium and right ventricle, we have the coronary groove. In this, we have right coronary artery running here. Look at that. Right coronary artery starts from the ascending aorta, and it runs into the right coronary sulcus. The same thing like left coronary artery originates from the aorta, ascending aorta, and then it's just come out here, and suddenly it divides into two main branches. One here, this is what we call anterior, it is coming down, so anterior descending artery, or it is between the right ventricle and left ventricle, and therefore we can say it is interventricular, in between, interventricular artery, anterior interventricular artery. And this another branch just loop around in the coronary sulcus, and therefore we will call it loop, circumflex branch. So these are the coronary artery, the right coronary artery and left coronary artery divides into left circumflex and left anterior descending artery. And the right coronary artery will give a branch here along the margin, inferior border of the heart. And therefore we say, hey, this is a marginal artery. And this right coronary artery continue to the posterior aspect of the heart and runs. And look at that, left coronary artery, left anterior descending, it is in the front of the heart, it is in the anterior surface, it is coming down, so anterior descending branch, or in other words, it is in between the two ventricles, interventricular artery. This interventricular artery will give branches to the right ventricle, of course, because it is close, but mainly to the left ventricle. And right ventricle is mainly supplied by the right coronary artery. Look at that. It is lovely diagram. And if you keep chasing the right coronary artery, here, right coronary artery from the front, it is just coming down here and continuing to the apex as the posterior interventricular artery. So now we know that at the front we have the anterior descending, and at the back we have the posterior descending. Yeah, posterior descending or posterior interventricular arteries. So posterior interventricular artery is a continuation of the right coronary artery, and anterior interventricular artery is the branch of the left coronary artery. And the veins, we follow the artery. The names of the veins are not that critical. But I want you to remember the coronary sinus. So coronary sinus is not an arteria, it is the venous. Look at that, all the veins coming back into the heart. Look at that, this vein, what do you call that? Great cardiac vein. And this vein, posterior vein of the left ventricle, another vein here, middle cardiac vein. So great cardiac vein, middle cardiac vein, and the small cardiac vein and posterior vein of the left ventricle. All the veins, look at that, go into the coronary sinus. Coronary sinus, it is in the coronary sulcus, S-U-L-C-U-S, sulcus, coronary sinus. Coronary means we know it is the crown, yeah? Crown, it is wrapping the heart as a crown from the here and down to the back. And it is coronary sinus is in the coronary sulcus together with the coronary artery. Look at the left circumflex artery is here. And this coronary sinus will drain into the right atrium. Yeah, so now all the veins go into the right atrium. But you know, that doesn't I think you better draw a diagram like this, like a free body diagram. From the aorta, right coronary artery come out, left coronary artery come out. Left coronary artery divides into left circumflex artery and left interventricular artery. Right coronary artery will give a branch which is called right marginal branch and continue backwards, going like that as the posterior descending artery. So it depends on which artery gets blocked. We expect, you know, which ventricle or which atrium is going to damage. As we know, interventricular artery is mainly for the left ventricle, but it will give some branch to the right ventricle. So if there is a blockage in the interventricular artery or anterior descending artery, the myocardial infarction is mainly going to damage the left ventricle. If the blockage, the thrombus is in the atherosclerosis plaque is in the left coronary artery, we are going to damage quite an extensive area. Therefore, if a patient has main branch left coronary artery blockage, then that is an early indication for the putting stents into the coronary arteries, because we cannot afford it, because this left coronary artery is giving a large portion of the heart, and therefore we cannot afford the blockage of the left coronary artery, and therefore we have to deal with this early. Yes, this is the more cadaveric diagram. We can see the right coronary artery running in the right coronary sulcus in between the right atrium and right ventricle. And you can see the marginal artery, which is running here. Left coronary artery here coming down as anterior interventricular artery or anterior descending and going to the back as a circumflex artery. This branch, don't worry about that. It is not always mentioned. It is, but this descending branch is going to the apex of the heart. So now we split the heart in a coronal section, and this is what we see inside the heart. We know that we have 4 chambers in the heart: right atrium, right ventricle, left atrium, and left ventricle. So I'm going to ask you a little question. What is the main difference interiorly between the atria and the ventricles?
The ventricles are more muscular and have all the
These,
yes, the
yeah,
papillary muscles.
Yeah, that is brilliant. Yeah, ventricles are very muscular because the ventricles, we have to pump blood against a big resistance. If you look at the left ventricle, look at the thickness of the ventricle, because it has to push at least our heart blood pressure is 120, 80, which means this ventricle need to push against 120 pressure. So it has a big, thick muscular muscle, and left atrium, we have to push against the pulmonary circulation, which is not as bad as long as we have a normal lungs. The resistance in the lungs are not that bad, and therefore the right heart has to push the blood into the lung, into the pulmonary circulation. So usually about 25, so therefore it is right ventricle is stay much thicker than the atrium, but not as bad as the left ventricle. Because of the much thicker muscle layer, left ventricle is more prone to myocardial infarction. Of course, it needs more oxygen demand because it has more muscle, which means if we give 100 liter of oxygen to this right ventricle and 100 liter of oxygen to left ventricle, then it might not be enough for this left ventricle because it is much bigger person. So he need to eat a lot more oxygen. And look at the interior surface. This is so smooth here, and this is so smooth here. So atrium's job is to accept the blood, contain it, and put it gently into the ventricles. So as we know, like this superior vena cava from all the bloods from the head and neck, and inferior vena cava from the lower part of the body, we all empty into the right atrium, and the right from the right atrium into the right ventricle through the valve. Which valve? What is the name of this valve?
The tricuspid?
Tricuspid. Yeah. So tricuspid means three. Cuspid, its valve has 3 leaflets. Tricuspid valve. And this tricuspid valve, through the tricuspid valve, and deoxygenated blood from everything used from our brain, head and neck, from all the muscles, come into the right atrium through the tricuspid valve, go into the right ventricle. Look at that. The valves open into the ventricle. Yeah, these valves do not open backwards. They open along the blood flow, and they are going to open into the ventricle. And the leaflets of the valves are being pulled like you're doing surfing, like water skiing, surfing. Like these are pulled with the strings. These strings are called chordae tendineae and the trabeculae carneae. These are the little muscles. They are going to attach to the chordae tendineae and go and attach to the valve leaflets, so that when the right atrium contract, the valve we have to close and make sure these valves do not go beyond the valve and go into the atrium. If the valve go beyond into the atrium, that is what we call heart valve prolapse. So let's say, in a few patients, they might be a bit lucky, and when they have myocardial infarction, when they have heart attack, they do not damage the big thick muscle. They just damage these papillary muscles and chordae tendineae. And then what's happened? These chordae tendineae, they rupture. So these chordae tendineae are no longer attached to the wall of the ventricles, papillary muscles, chordae tendineae, trabeculae carneae. They are not attached. So when the ventricle contract, squeeze, the atrium tricuspid valve go back into the atrium. This mitral valve go beyond where it should be and go into the atrium. That is what we call heart valve prolapse because of the myocardial infarction. And that is also a very annoying problem because the valve, which is supposed to close and seal in between the two chambers when the ventricles contract, and now it is incompetent to do the job because they have lost their chordae tendineae, trabeculae carneae, and papillary muscle. And that in that case, when the ventricles contract, the valve is incompetent and the valve goes into the pulmonary circulation, at the same time leaks back into the atrium. So that is also another annoying and difficult problem to solve. So right ventricle, right atrium, we take all the blood from the deoxygenated blood from the body through the tricuspid, come into the right ventricle through the pulmonary valve. Hey, look at that, pulmonary valve has to open along the flow and open into the pulmonary circulation. This is what we call pulmonary trunk. This pulmonary trunk we divide into right and left pulmonary artery. And as we say, like artery and vein is depends on where they come and where they go, regardless of what they contain. So pulmonary artery will contain deoxygenated blood, and when they will go to the lungs, get reoxygenated, and that reoxygenated blood come back to the heart along the pulmonary vein. So pulmonary veins carry the oxygenated blood, and pulmonary artery carries the deoxygenated blood. Look at that. Yeah, that's a little catch here. So artery or vein depends on where they leave. So anything leaving the heart, we will call it the artery, and anything coming back into the heart, we call it vein. So now the oxygenated blood come back from the lungs into the left atrium via the pulmonary veins. Okay, how many pulmonary veins do we have? At least two on the left and two on the right, going into the left ventricle. And through the mitral valve, as you can see, the same structure like right atrium, we go into the left ventricle. From the left ventricle through the aortic valve. Look at that here, aortic valve here. And now we can appreciate the aortic valve is more posterior to the pulmonary. So, and then aortic valve, we go through here along the arch of aorta into the systemic circulation. So look at that, look at the thickness of the left ventricle, left atrium, right atrium, and left atrium. Okay, so I hope you all understand how the blood goes through the heart, right atrium, tricuspid valve into the right ventricle, through the pulmonary valve into the pulmonary circulation, and can get oxygenated, and then come back into the atrium through the pulmonary veins, from the left lung, left pulmonary veins, from the right lungs, right pulmonary vein into the atrium. Atrium walls are smooth. Through the mitral valve, can into the left ventricle, and we through the aortic valve, we go to the systemic circulation. And the heart is covered with the pericardium. The lungs is covered with the pleura. The abdominal viscera are covered with the peritoneum. And the brain is covered with the meninges. We all know that already. And pericardium has fibrous pericardium and serous pericardium. Fibrous pericardium is the big fibrous tissue sheet which split the heart with the rest of the thoracic cavity, which is like ribs and bones and that sort of stuff. And serous pericardium has 2 layers, visceral and parietal layer. Of course, visceral means closer to the heart, and it is also called the epicardium. And parietal is the layer which lines the fibrous pericardium. So visceral peritoneum, visceral pericardium, parietal pericardium. Visceral pericardium is also called epicardium. And layer of the heart, we know that. If we don't know something, just say 3, yeah? 3 layers. What are they? From inside to outside, endocardium, myocardium, and epicardium. Endocardium, myocardium, and epicardium. Yes, epicardium is the one we saw, visceral layer of the serous pericardium. So what is endocardium? It is the same like any other structures in our body, innermost related to the exterior. It is the epithelium, which is the flat cell, simple squamous epithelium. Of course, it is in the heart, and therefore we will change the name into endocardium. So endocardium is the innermost layer which is in contact with the blood. And now we get to the myocardium. Hey, myocardium is the muscle of the heart, isn't it? Myocardium. And epicardium is the visceral layer of the serous pericardium. And the pericardial fluid is in between the visceral and parietal layer of the serous pericardium. Outside this serous pericardium, we have the fibrous tissue, which is keeping the heart in its position so that the heart doesn't jump out. The heart doesn't jump out and then go away from the place. Now, if we look at that, look at this, the innermost layer, which is in contact with the blood, it is called endocardium, endocardium layer. This is the muscle layer, which is the myocardium, and this is the visceral layer of the serous pericardium, which is closely covering the myocardium, and therefore we call it epicardium. And this is the parietal layer of the serous pericardium. This is a space which we call pericardial cavity, and outside this we have the fibrous pericardium, which keeps the heart in its position so that the heart cannot jump away inside the thorax. So now let's look at the heart muscle, because we know that this endocardium is like epithelium, which is made of flat cell, squamous simple epithelium. And now we need to know a little bit about the myocardium. Look at this myocardium. Oh, if you look under the microscope, this is what you are going to see. Okay, so this is myocardium. It is a cardiac muscle cell, cardiac muscle tissue. So how many muscles can you remember? How many different types of muscle tissue can you remember?
Smooth, cardiac, and skeletal?
Yeah, smooth, cardiac, smooth, and skeletal. That's what you say. So yes, 3. So I am going to remind you a little bit. As we know, a human being is multi-billion cellular organism, isn't it? We are made of billions and billions of cells. Cell is the structural unit of the human being. So if we group the cell into different types, then we got the tissue, right? Tissue is the combination of cells which has got same function. So how many types of tissues in our body?
4.
4. Okay, number 1.
Epithelial.
Epithelia. Number 2.
Connective tissue.
Connective tissue. Number 3,
Muscle.
muscle tissue. Number 4,
Nervous.
nervous tissue. So you and me, we are all made of only 4 tissue. Doesn't really matter how many billions of cells we have. We are finally, all these billions of cells become only 4 tissue. That's a human being. Yeah. So epithelial tissue, you have seen it already because it is very early in your lecture. So if you like, we can divide into epithelial tissue into, like, depending on the shape, like flat, squamous, little bit cubic shape, cuboidal, very tall, columnar, or pseudo, or transitional. That's one way to classify the epithelial tissue. And another way to classify it is depending on how many layers, like simple or pseudo stratified or stratified epithelium. So that is the epithelial tissue. And connective tissue, like, as you remember, the bone, cartilage, blood, the loose areolar connective tissue, tendons, these are all connective tissue. Muscle, now you are dealing with, you have told me already, like cardiac muscles, smooth muscle, and skeletal muscle. And nervous tissue is only one, and only, of course, nervous tissue means even nervous tissue is made of neurons and neuroglia cells. That is the nervous tissue. So now let's concentrate on our cardiac muscle tissue. And if you get this slide under your microscope, you know that this is a muscle tissue. Why can you say that this is a cardiac muscle tissue? What is the reason?
Because of the branching.
Branching, perfect. It's branch here, and branch and unite here. This is uniting. It is branching. That's number 1. And number 2 is we have striations here, yeah, like a snake, you know, striations here, striation. So cardiac muscle is a striated muscle, but not slightly different from skeletal muscle. Is they do branch and they do join, branch and join with the striations. Therefore, this is the cardiac muscle. So now if you get a slide under your microscope and look at that, and you see a few little nucleus here and there, that is the cardiac muscle. Of course, this is the skeletal muscle. These striations are very prominent, and they do not branch, they do not join. They do not branch, they do not join. They are big, long, cylindrical muscles, striated cells, and therefore this is the skeletal muscle. Look at the shape the book has drawn. It is very typical. And now if we go back and look into the smooth muscle, hey, smooth muscle is just like a little piece of you know, tissue, like just damping on each other. Like that is a smooth muscle. It is not striated. It is a non-striated muscle. So skeletal, cardiac muscle, they do branch or they do join, and they are striated. You can see the striations here. You can see the striations here. The smooth muscles, there is no striations. That is very structurally, they are very different from the cardiac or skeletal muscle, and the skeletal muscle is grossly obvious. Brilliant. So cell and tissue, cell is the structural unit of living, and tissue, the group of cell with the same function. So it doesn't matter how many billions of cells we have, finally, they all become 4 different types of tissue: epithelial tissue, connective tissue, muscle tissue, and nervous tissue. That makes a human being. And cardiac muscle is a striated muscle. They are short, they do branch, they have some centrally located nuclei, intercalated disc. I did not include that slide, intercalated disc, because I don't want you to just go too deep into the cardiac muscle. Yes, of course, you know, for the sake of exam, I want you to go through the textbook or go through the lecture slides. But in long term, you know, these intercalated discs are not going to be useful for you in your clinical practice for a long time. until you become like specializing in the cardiac muscle. And therefore, I'm just going to leave it because now we are revising for the next step, and therefore we need to pick up what is important in life. And don't forget the cardiac skeleton. Don't forget the cardiac skeleton. The cardiac skeleton is the dense connective tissue, and these dense connective tissue give the structure of the heart. Because if we just leave it as with the muscles and the endocardium, myocardium, and pericardium, then the heart shape will change, like whatever it happens, like in cartoons. So we can make it like that. So this we have to protect and give the structure of the heart, and keep the structure by keeping the connective tissue, which is called cardiac skeleton. It gives attachment for the valve, attachment for the muscle, prevent the overdilatation of the valve, make sure the heart is in its shape, not too wide, not too constrict. And these connective tissue, they stop the direction of the electrical impulse, which is generated from the SA node, sinoatrial node, which is located in the right atrium, so that the electrical impulse from the SA node will not go wherever they want. They have to follow the route, follow the pathway of the pathway which is already planned already. So these cardiac skeleton will block the electrical impulse. And look at the arrangement of the muscles you are talking about, like cardiac muscle and their arrangement. Look at that. Around the atriums, they are very much circular, so that when they contract, the blood cannot go anywhere, just go directly down. But if you look at the muscles for arrangement for the muscles of the ventricles, they are all twist and windy, and therefore the left atrium contract, the heart will go to the right, and the right ventricle contract, the blood will go to the left side. So it's just like crossing like that because of the arrangement, circular arrangement and spiral arrangement of the cardiac muscle at different places. Like atrium, it is very much like circular, and in the ventricle, it is more spiral shape. That is cardiac skeleton and cardiac muscle. All right, so it's 11 o'clock now. We will take a break for about just 10 minutes. I want you to go and wash your brain. Just go and get some coffee, tea, have a fresh air, go away from the computer, and we will meet 11:10. Is that all right? So 10 minutes break. 10 minutes break. Okay, thank you. And we will meet 11:10. Okay. Okay, let's start. It's 10 past 11. So 10 past 11, let's start. I hope everyone is back. And this is our heart. This is a very good diagram. Like everything from the periphery, from the body, use the oxygen from the blood being taken back to the heart and go into the right atrium via the inferior vena cava, superior vena cava, go into the right atrium through the tricuspid valve, go into the right ventricle, through the pulmonary valve, go into the pulmonary trunk, and go into the right pulmonary artery and left pulmonary artery. They go to the lungs, and as they are circulating in the pulmonary circulation, they will get re-oxygenated, and carbon dioxide and oxygen exchange there in the lungs and then come back to the heart. Look at the two pulmonary veins from the right lung and two pulmonary veins from the left lung. We go into the left atrium through the mitral valve, comes into the left ventricle, and through the aortic valve, we go into the systemic circulation, and it will be distributed to the whole body, this oxygenated blood, and then that will be used and it come back again. So this diagram, for me, it is very, very well explained. It is very well explained, which is really, really nice diagram. And I believe, you all understand this already. Okay, so now this is the further explanation, like the blood from the superior vena cava, inferior vena cava, get into the right atrium, and then right ventricle, go into the pulmonary trunk and pulmonary arteries, then go to the lungs and get re-oxygenated, come back to the left atrium, and then left atrium feed through the mitral valve, come to the left ventricle, and then from the left ventricle being squeezed out into the systemic circulation, and the oxygen will be used from the cells. So yes, I believe you understand this concept. And if you look at the heart valves, as we say, tricuspid, three, cuspid means caps, so 3 cups. So here, look at that, 1 cups, another cuspid, and another cuspid, so 3 cusps. So if you look at a simple diagram here, look at the simple diagram, this is the tricuspid valve. It has got 3 valves. And all the heart valves, like aortic valve, pulmonary valve, they all have 3 valves, although the tricuspid valve is only named tri. But except the mitral valve. So we have 4 valves in our heart, tricuspid and mitral, atrial and pulmonary. So except the exception of mitral valve, all the valves are 3, tricuspid valves. And mitral valve is only 2 leaflets. Look at that, 2. One here and the other one here. Therefore, we can say mitral valve is bicuspid valve. So tricuspid valve and bicuspid valve. Bicuspid valve is mitral. The rest is tricuspid valve. Yeah, so this is the tricuspid valve. So the heart sounds, this is from our textbook. The one I show is from another book. So these are where you listen. Of course, the tricuspid might be slightly more inside here. We should listen. Aortic, pulmonary, apex slightly away, mitral, and tricuspid might be somewhere around here. The first heart sound, why do we have first heart sound? Because the blood from the atrium will be squeezed into the ventricles. Now the ventricles, right and left ventricles are filled with blood already. And now the ventricles start to contract. And once at the beginning of the ventricular contraction, on the right side, tricuspid valve has to close fast. On the left, mitral valve, we have to close fast. And then if the ventricles keep contracting, because it is all contained and enclosed already, and the blood will leave the ventricles via the pulmonary and aortic valve. So at the beginning of the ventricular contraction, the mitral and tricuspid valve we have to close fast before the blood can be ejected out of the ventricles. And therefore, these mitral and tricuspid valve closure we heard as a first heart song, which is books described as LUB. And the blood now squeezing out, heart valve, tricuspid and mitral valve being potent and competent, close, the ventricle pressure rise, the blood go through the pulmonary and aorta. And now when the ventricle relax, these pulmonary valve and aortic valve open and now close again. The closure of the aortic and pulmonary valve make another sound, which is called the DEP, atrial and pulmonary valve closure. So you listen someone's heart and you are hearing LEP, DEP, LEP, DEP. That's the book described. You might hear slightly different, but that might because it is universally accepted, and therefore I think it is okay. LEP, DEP, LEP mean mitral and tricuspid valve closure at the beginning of the systole, and DEP mean closure of the pulmonary and aortic at the beginning of the diastole, at the end of at the diastolic period. So systolic and diastolic period and LEP and DEP, that's what we hear. So the valves, as we saw, the valves can be incompetent, like they are trying to close, but it is not fully closed. Or the valves, instead of this side, might be smaller, which is called stenosis, narrowing, or the valves will prolapse into the opposite chamber, like tricuspid and mitral valve. When the ventricle squeeze, the chordae tendineus being damaged cannot pull, and then they will go back into the atrium. That is what we call the prolapse valve. Incompetent valve means the heart valves are trying to close, but they are not competent enough to close. So it is not watertight seal. Therefore, when the ventricles contract, the bloods are leaking out from one side to another. And what is a murmur? Murmur is the turbulent blood flow which we can hear. That is a murmur. A murmur is a audible, which is something we can hear, turbulent flow. So if the stream is flowing, then we won't be able to hear the flow. But if the flow being disturbed, it becomes turbulent flow and we can hear it. That is the audible, the turbulent blood flow in the heart. It is the murmur. So a murmur can be due to stenosis. Of course, this amount of blood will have to go through this side of the heart valve. And if the size is small, then there will be like a pressure and we can hear it as murmur. Incompetent, the valve, which is supposed to close, but it doesn't close, and therefore we can hear a murmur, or prolapse valve we can hear as a murmur. Anyway, whatever it is, a murmur is a turbulent flow which we can hear. These are the possible valve disorders. So now let's look at that, the heart, the nerve supply, the heart, it is something like we don't really need to bother about, isn't it? Because it is under the autonomic nervous system. It is beating for us without, we don't have to make any effort. Even when we are sleeping, the heart continues to beat. And of course, our emotion, our limbic system, our frontal lobe emotions, everything can change the heart rate as well. But how do we get autonomic nervous system for the heart? Look at that brainstem. Brainstem include midbrain, pons, medulla oblongata. Yeah, combination of three makes the brainstem. Brainstem is midbrain, pons, medulla oblongata. And brainstem has respiratory center. We saw that already. And the brainstem has the cardiac center. Look at that cardio-inhibitory center here. Dorsal motor nucleus of the vagus here. So cardio acceleratory center here. So the accelerating and decelerating, all these centers are inside the brainstem. Therefore, as I say, the brainstem stroke involving the brainstem is really, really disturbing. It could be fatal because brainstem has got vital centers, which is like a respiratory center, cardiac center, and limbic, all like reticular formation, everything reticular formation, just like sleep and wake and alertness, or everything is in the brainstem, and therefore brainstem is very important for us. So now in the brainstem, part of the brainstem, which is medulla oblongata, midbrain pons, medulla oblongata, we have the vagus nerve nucleus. Look at that dorsal motor nucleus of the vagus. Vagus has inhibitory effect, isn't it? Vagus is going to slow down the heart. Vagus, the job of the vagus is rest and digest. Rest and digest. Therefore, the vagus nerve will slow down the heart rate. And if you look at the cardio acceleratory center, which is here, this is the go into the sympathetic ganglion and come to the heart. Of course, sympathetic, it is for fight and flight. So it will fight and it will run away. So it will increase the heart rate. But the vagus, which is inhibitory, and sympathetic, which is stimulatory, they need to get balanced so that our heart rate is maintained around 70, 80, which we call normal. Of course, normal heart rate in theory goes from 50 to 100. But usually most of us, we have like, 70, 80 beats per minute. For us to get this heart rate, our parasympathetic nervous system, which is via the vagus nerve, and sympathetic, look at that from the cardio acceleratory center, from the medulla oblongata, look at that. And that is we have to get balanced together. And finally, the vagus or the sympathetic, they will go to the sinoatrial node, SA node, and they will go to the atrioventricular node. And sympathetic might go to the heart directly as well. So let's look at the conduction inside the heart. Conduction in the heart. It starts from the sinoatrial node or SA node, which is located in the right atrium. Inside the right atrium, just inferior to the entrance of the superior vena cava. And from the SA node, it has to go to the AV node. Of course, it doesn't go everywhere it likes. There is a pathway which we call internodal pathway. From SA node to AV node, go from SA node to AV node via the internodal, in between the node pathway. From the AV node, it will go into the ventricle as AV bundle. It is also called His bundle, bundle of His. And then it will finally divide into right bundle branch and left bundle branch. And finally, they will diverge into Purkinje's fiber. Look at that. From the SA node here inside the right atrium, this is the superior vena cava. This is the superior vena cava. This is the SA node, sinoatrial node. You saw that from the vagus and sympathetic, we come and act on the SA node. From the SA node, look at the yellow line, which is called internodal pathway, and it will go to the atrioventricular node. Atrioventricular node here. From the atrioventricular node, it will go into the ventricle via the atrioventricular bundle. Look at that. Atrioventricular bundle or bundle of His. And finally, once it gets into the interventricular septum, it divides into right bundle branch and left bundle branch. So when you look at an ECG, the SAM ECG will report as a right bundle branch block or left bundle branch block. That means these bundles, right bundles and left bundle, that is a conduction block. And of course, finally, this right bundle and left bundle will finally divide to become the bundle of His or the subendocardial conduction network. Look at that. That is the flow where it should be. So from the SA node through the internodal pathway, go to the AV node. From the AV node, it has to go into the bundle of His bundle in the interventricular septum. And when it gets to the interventricular septum, it will divide into right bundle branch and left bundle branch. And then finally, these ventricular muscles get stimulated. So that is the normal pathway of the heart electricity. So the SA node start from SA node, go to the some atrial tissue and left atrium as well. Look at that. In the nodal pathway, it will go to the AV node. And therefore, the atrium will start contracting first. So once there is a stimulus, atrium will contract, the blood will flow into the ventricle, and this electrical impulse will come and stimulate the ventricle wall, and ventricle will contract. So that's the way, we are contracting our heart. So I want you to remember from SA node, internodal pathway, AV node, AV bundle, bundle of right bundle branch, left bundle branch, and then finally divide into Purkinje's fiber, subendocardial conduction network, Purkinje's subendocardial conduction network, Purkinje's fibers. So these are the inciting muscle. So if you remember that, you are safe. And this is the electrocardiogram, EKG. That's what we call EKG. In Europe, in UK, it is called ECG, electrocardiogram. In US, it is called EKG. Why do we call EKG? As far as I know, EKG is a German word. So EKG or ECG, look at that, the heart is here. We know where the heart is because we know the surface anatomy. And EKG, you're looking at the heart from 12, like standard 12 lead EKG is you're trying to look at the heart from 12 different angles. So yes, this is our heart. You can see the V wave, the V1, V2, V3, V4, V5, V6. So these 6 leads looking at the anterior surface of the heart. And we have the augmented vector right from the right shoulder, augmented vector left from the left shoulder, and augmented vector inferior AVF, looking at the heart from the bottom. And on top of that, the lead 1, lead 2, lead 3. So altogether, 6 blue, 6 red. That's the way we look at the heart from the very different angles. So if there is an inferior wall infarction, which might be from the right atrium or might be from the right ventricle, or might be from the left ventricle, because left ventricle contribute to the inferior wall, right ventricle also contribute to the inferior margin. And if there is a myocardial infarction, then in the inferior, that must be seen on the 2, 3, and AVF. Therefore, we say, hey, inferior wall infarct, look at the 2, 3 AVF. So anterior wall, like for example, right ventricle, which makes the anterior, most of the anterior wall, might be on the right. So V1, V2, V3, V4 changes. That is for the right ventricle, and V5 and V6 changes, that might be for the left ventricle. Of course, you know, this is just for the brief and limited information, but trying to relate the EKG, which is you are going to use in your daily life, and our heart anatomy. So that's the way we try to relate the anatomy knowledge into clinical practice. And now we got to the EKG. So let's move on. That's for the heart. And let's move on to a few more slides because we are going to talk about these for Wednesday. Yeah, so for Wednesday lecture, I'm going to start a little bit so that you don't have too much information on Wednesday. So this is our brain. In the brain, we have our brain substance itself. We have the venous blood and arterial blood, and we have the CSF. This is the flow of the CSF. If you look at that, choroid plexus here, choroid plexus, which is lined by the ependymal cell, will secrete the CSF, which is called cerebrospinal fluid. Yeah, so cerebrospinal fluid will be formed from the choroid plexus because choroid plexus has got ependymal cells. I believe you remember ependymal cells. And now CSF start in the lateral ventricle. From the lateral ventricle, it will go into the third ventricle. And from the third ventricle, it will go into the fourth ventricle. And now finally go into the subarachnoid space and in the central canal of the spinal cord. So what I want to mention here is our cranium. Our cranium is a rigid box. It cannot expand. It cannot collapse. It is a rigid box. Cranium is a rigid box. Inside the cranium, we have our brain. We have our venous blood and arterial blood, and we have CSF. It is limited. It is tightly controlled. The content of the cranium is tightly controlled. If there is one extra, then if there is one extra, then we need to change. Okay? We need to change. So we cannot accept any more extra. That is the cranium, which is a rigid box, which is have the volume of the brain, blood, and the cerebrospinal fluid. That is the cranium. That is what we call Monro-Kelly doctrine. Cranium is a rigid box, and the blood and the brain, and the CSF is need. If one increase, like for example, brain tumor, there will be less blood flow to the brain, or there will be less CSF. Or if there is loss of CSF inside the brain, then the brain needs to go somewhere because it cannot stay. So the brain and brainstem will come down along the foramen magnum, go up, and that is what we call the brainstem prolapse. So we don't want that. So it is all tightly controlled. Look at this person, and this is the damage to the temporal region. Look at the ear. Everything is ripped off here. So we can imagine what sort of injury he is going to have inside his cranial cavity. Yeah, look at that. So on the right side, the temporalis muscle might be damaged. The temporal bone might be broken. The external ear is damaged, and this is not not an easy injury. So there could be a bleeding inside the cranium, which we call intracranial bleeding. Okay, so that is the head injury, the central nervous system. We are going to repeat a little bit on Wednesday, as well as look at that. What are we seeing here? Okay. So I have two photographs here. This is a guy who has got this black here around the hip. And this is a guy who has got like a bed sheet around the waist. What are these? Michaela, Vicky, George, Michelle?
Sorry, what was the question?
Oh, so we can see here, you know, this patient being tied around with the, I think this is a big bed sheet being pulled together, and this guy has got black sheet around the hip or pelvis region. What are these?
I don't know.
These are the what we call pelvic binders. Yeah. So this is the proper formal pelvic binder. So like if you squeeze together, the pelvic will be squashed like that. And they do not have this proper formal pelvic binder. So if we do not have it, we are going to use this bed sheet to squeeze the pelvic together. Because the reason is the patient has got this injury. Look at that. The motorcyclist, like a big tank in front of him. He hit his pelvis with the motorbike tank, and then he just thrown away. And his pelvis has been opened up. That is what we call open book pelvic injury. Look at that. And if you do that, if you see this, you know that there is a lot of bleeding inside the pelvic already, because inside the pelvis, we have our common iliac arteries, iliac veins, everything, big major vessels. Pelvic bleeding is fatal. And if we do like that with the pelvic binder, and this injury became this injury. So it reduced the pelvic volume. It's all squashed together. That is what we call pelvic binder. Of course, if you have something like that, proper formal pelvic binder, then it's great, you can use it. But if you do not have it, don't worry too much, don't think too much. Just squeeze the pelvic together with the bed sheet, whatever you can have. Squeeze them together to get it, so that this injury might be far better than this injury. Yeah, so that is what we call the pelvic binders. So pelvic binder is you have to tie around the greater trochanter region, not in the waist. It is on the greater trochanter of the femur. You have to put around this area. And on top of this pelvic binder, what can you see here? You can put you can see the urinary catheter, or might be a femoral venous access here, somewhere in the groin tube here. And what is this? This is the scrotum, which is bruised. Look at that. That means this patient has pelvic injury, proper pelvic injury. The external genitalia bruising of the external genitalia. At the tip of the urethra meatus, you can see the blood. And if you do a digital rectal examination or bar rectal examination, it is like you can see some tear inside the rectum and that sort of injury. That means, hey, it is really, really fatal injury. Just try to get on and let's sort it out properly. So this pelvic bleeding, pelvic injury can bleed and bleed and bleed. It could be both arterial bleed, it could be venous bleed, and it is really, really heavy bleed, and it is fatal. So if you suspect any patient with the pelvic injury, you need to put on the pelvic binder. This pelvic binder is proper, formal, with the Velcro. And if you don't have it, don't worry too much. Just tie with the bed sheet in the ER. That saves the life. It will change this injury, which is really open book, into this injury. At least it is better. It reduces the pelvic volume. It puts the bones together to some extent. But yes, it reduces the volume of the pelvis, and therefore it is life-saving. Look at that. This is the different types of pelvic ring injury. And this is the open book, which we see. So this is the anterior and posterior compression. So usually, you know, at the right height, the car bumper hit the pelvis, or the motorbike, you know, big tank, the motorbike accident, just the pelvis hit the motorbike tank directly, and it's just blown out like that. That is what we call the AP, anterior and posterior compression pelvic ring injury. And if somebody fell on their side of the pelvis, that is what we call lateral compression. Or if the patient is walking and being hit by a car from the side, that will create the lateral compression pelvic injury. So you will see the fracture on the superior pubic rami, inferior pubic rami, of course, depending on the how big the energy is. So look at that. This is the vertical shear. Look at that. One hemipelvis is going up and one hemipelvis is remaining. So what sort of injury can give this vertical shear?
Maybe falling on one leg somehow or something.
Yeah, you are right. Usually, let's say a little monkey tried to climb the tree and then fell off from height, bang. So just stand on one leg, and that leg, let's say this person might have stand and fall, vertical fall, and then land on one leg, and then just one hemipelvis being pushed upwards. And this is so disturbing and damaging injury as well. Of course, you know, the open book bleed this will give us like a lot of neurological injury. But you know, if you see a patient like our previous these diagrams, so if once you see a patient, like if you're walking for the emergency medical services, and if you see you have to assume, and that therefore these days, like unless you know there is a good indication not to do, lots of emergency team we do that put on a pelvic binder because we don't know. And let's say this injury will solve this sort of injury, but might not solve this sort of lateral compression, might create more injury. And this is we are not doing anything by using pelvic binder. But if we look at that, you know, this not doing so might be more damaging. And therefore, if we any major body trauma, then we just put on a pelvic binder. Of course, you know, if it is grossly opened up, then it is more, you know, we can do a better job with certainty. So that is the pelvic ring injury. And let's talk about the different parts of the pelvis. So this is the sacrum. We have 5 sacral vertebrae, which is fused. And you can see the sacral foramina here. These are the spinal nerves coming out from the sacral foramina. And this is the ilium. I believe you all remember that. This is the ischium, and this portion is at the front is called pubis bone. And this is the pubic symphysis. So right hemipelvis and left hemipelvis come and join in the center. This is the pubic symphysis. In theory, 2 bones joining together, and therefore pubic symphysis is a joint. Yeah, so this joint, it is cartilage and fibrous tissue, and therefore we call it secondary cartilaginous joint. And now this is the right ilium, this is the left ilium, this is the superior pubic rami, this is the inferior pubic rami, and this is the ischium. Yeah, so at the bottom, if you are sitting down, you are sitting on your ischium. So ischium here, ischium will be somewhere here. And if you have to follow the inferior pubic rami, and finally it comes to the ischium. So this bony prominence is anterior pubic rami, anterior superior iliac spine. This lower is inferior. This is superior and inferior. Anterior, superior, and anterior, inferior iliac spine, anterior ASIS and PSIS, anterior superior iliac spine, anterior inferior iliac spine, and this is what we call iliac crest, and this is the ilium bone. Yeah, so this is the iliac crest because it is a crest-like. It is a crest, iliac crest. This is the ilium, and this is the anterior superior iliac spine, and this is the anterior inferior iliac spine. And this is the socket for the femur, which is what we call acetabulum. And this is the superior pubic rami, inferior pubic rami, pubic symphysis. What is this foramen called? That is the obturator foramen. Yeah, so I believe you all remember that. This is the obturator foramen. So right obturator foramen, left obturator foramen, and we have the obturator neurovascular bundles. So obturator nerve and the obturator vessel come out from the obturator foramen. So if this sort of, and again, like as we remember, the pelvic ring is a polo ring, isn't it? It is like a heart, like the polo ring. So you cannot break in one area. If you break in one area, there will be another area which will get damaged. So if you look at that, if we have damage to the anterior pubic symphysis, then there will be damage to the sacroiliac joints. Look at that. And the same, you know, if we have fracture here, then there could be a damage, or at least minor damage, to the posterior pelvic injury. So this is what we call anterior pelvic ring injury, and they will have, or they may get, or they are highly likely to get posterior pelvic ring injury. Look at that. If we damage the front, we will damage the back. So that is, so when we see on Wednesday, we will talk about nervous system, like, you know, some try to all get back together, and we will talk about the bony skeleton. So yes, as an anatomy student, you know, you need to know the bones and the different parts of the bones in our body. And so we are going to repeat the anatomy or skeletal anatomy, and we repeat the nervous system, because that comes into disability and deformity. Yeah, so deformity means bony fracture, and disability means neurological injury. That's what we will talk about on Wednesday. All right then. Has anyone got any question?